All right, so we're going to go ahead and get started. Just want to welcome you all and thank you all for joining us today for this webinar on refugee and immigrant access to healthcare. My name is Dr. Nicholas Rummel, and I am a health equity intern with the Tennessee Justice Center. And I am going to lead you on this journey of refugee and immigrant access to health today. The webinar should take about an hour, give or take. Have some time for questions. If you do have any questions, please put them in the question and answer box or in the chat. I will just forewarn you that I cannot usually see them while I'm presenting, so I will probably get to them all at the end. For everybody who registered, a recording and the slides will be presented once that's all processed after the fact. And again, check out our website there at the bottom for future events from Tennessee Justice Center. So, one disclaimer I want to make at the beginning here. This is titled Refugee and Immigrant Access to Healthcare. This is going to be heavy on the refugee side. So a lot of the stuff is transferable to immigrants, but my background is working with refugees and researching refugee access. So there's a lot of focus on refugees in this webinar, just to give you a heads up. Again, presenting today, Dr. Nicholas Rummel, health equity intern. My email is on there. Contact me if you have any specific questions or want to learn more, talk about it more. And a brief little look at our agenda today. We'll just start off with a brief overview of TJC and what TJC does. I'm going to talk a little bit about refugees in Tennessee, where they come from, what some of the barriers they have. We'll talk about refugee medical assistance, about Medicaid through TennCare and Cover Kids, about the marketplace. And then my specific research in my dissertation was on access to family planning services. So there'll be a special little focus on access to family planning services, and then we'll kind of wrap it up. So about the Tennessee Justice Center, just briefly, as you can see on the screen here, Tennessee Justice Center focuses on individual client representation, promoting enrollment, healthcare and nutrition programs, litigation to correct issues, and advocating for legislative administrative changes. Specifically where I am on the health equity side, in terms of health equity, Tennessee Justice Center believes that all people, regardless of color, faith, gender, wealth, background, ability, or otherwise, deserve to live with dignity and health. And our mission then is to ensure that laws, policies, and programs reflect and honor the value and potential of every human being. So, of course, there's more information on the TJC website if you're interested. I'm sure many of you are probably already familiar with what TJC does. So diving into this topic then, I'm very excited and honored to be presenting today on this research with refugees, especially since we just had World Refugee Day last week on June 20th. And so just a brief background, because I think it's important to understand some of the differences in terminology. Internationally speaking, refugees are individuals who are forcefully displaced from their home country due to a well-founded fear of persecution due to their race, religion, nationality, social group, political opinions, and the like. In the United States, we follow that same definition, but it gets a little tricky when we talk about refugees versus asylum seekers versus immigrants. And oftentimes all these groups are just kind of put together into a larger group. So in the United States, a refugee follows that same definition of forcibly displaced for well-founded fear, but also to be considered a refugee by the United States, you have to be outside of your home country and outside of the United States. If you are in the United States or at the US border, then you would not be considered a refugee, rather you'd be considered an asylum seeker. And this leads to a lot of confusion in when you look in the literature or when you even read policy in other places like Europe. They often consider refugees and asylum seekers the same thing because most of the time they are arriving at their borders. So it does lead to a little confusion. The other issue is when it comes to refugees versus immigrants. Technically speaking, immigrants are persons who make a conscious choice to leave their home country and to move to a foreign country. Usually they do this through some kind of immigrant visa or finding other means. And then migrants specifically are people on the move in search for a better life or better work. They have not made a decision about moving or resettling, but they're not qualified as refugees because they do not meet that well-founded fear criteria. Now, of course, in today's world, there's a lot of talk about illegal immigrants, illegal immigration, and migrants. Most of the people who are in the United States illegally are immigrants who overstay visas or migrants who overstay migrant visas. So to look specifically more at Tennessee, then Tennessee ranks as the 18th most common state for refugee resettlement in the US. And that might seem surprising considering some of the policies and laws in Tennessee, but we are consistently in the top 20 in terms of the amount of refugees resettled in our state. Over the last 10 years, about 10,000 refugees have been resettled in Tennessee. And the top countries of origin for the refugees who come to Tennessee are kind of labeled on this map. The majority, the top 5 or 6 are Iraq, Somalia, Myanmar, the Democratic Republic of Congo, Bhutan, and Sudan. And then it's kind of hard to see on the map, but any other countries you see on there with lines through them are other countries where there are substantial populations of refugees in Tennessee. At last count, I think there are about 40 different and maybe 45 different countries represented by refugees in the state of Tennessee currently. About 50% of the refugees in Tennessee are women and children, especially the more recent ones because of conflicts in places like Iran or Ukraine and Palestine, where the men are often left or stay behind to fight. And the kind of profile of the refugees in Tennessee, roughly about 45% of the refugees in Tennessee are Muslim, about 30% are Christian, and about 25% as other. The majority of the refugees resettled in Tennessee end up in one of the 4 big metropolitan areas, either Nashville, Memphis, Knoxville, or Chattanooga. These are pretty rough numbers, but Nashville gets over 50% of the refugees that come to Tennessee. Memphis and Knoxville get about 18 to 20%, and then Chattanooga, the remaining 8 to 10%. So with all of these refugees in Tennessee, they do face numerous barriers to access when it comes to healthcare and medical assistance. Just a brief overview of some of these barriers. Of course, many of these are pretty self-explanatory and pretty obvious. You've got your language barriers. Many of the refugees don't speak English at all, or especially not as their first language. Cultural barriers, financial barriers, and we usually include in those financial barriers the insurance barriers when we talk about health, logistical barriers, getting around, getting to health appointments, not having a vehicle, not having childcare for other children, discrimination. Many refugees are seen as minorities. They are seen as others by the home population and are often discriminated against. Religious barriers, depending on where they come from, what their beliefs are. And then, of course, especially in places like Tennessee, we have numerous policy barriers, whether that comes to Tennessee being one of the states that has an expanded Medicaid, whether it comes to sexual reproductive health barriers, such as the Dobbs decision and the trigger laws in Tennessee. And then acculturation is also considered kind of a barrier because when refugees are resettled, their number one goal, according to the government who is resettling them, is for them to become self-sufficient as soon as possible. So many refugees, when they resettle, they're focused on getting a job, getting English language skills, getting their children into schools. A lot of times they don't focus on their health care. They don't concern themselves with it. Many of them don't even look for healthcare or look for insurance until they absolutely need it. So that process of kind of almost being pushed in the direction of acculturation creates another barrier for healthcare access for refugees. The one program that's really supposed to help refugees when it comes to accessing healthcare and medical services is known as the Refugee Medical Assistance Program, or the RMA. The RMA is an insurance-like program that covers refugees who cannot get insurance and who do not qualify for Medicaid. This RMA coverage is limited to 8 months, and there's an asterisk there because currently it's up to 12 months with some changes that were made during COVID, but at any minute here it could go back to 8 months. And just a quick little background, when this program began in the 1980s, the RMA assistance was available for 36 months for refugees. But between 1980 and the mid-90s, it went from 36 months down to 24, down to 12, and then down to 8. And it had stuck at 8 months since the mid-90s until COVID, when they bumped it back up to 12 months. Now, while this is a great plan and a great program for refugees, there's also a bunch of hurdles with it. In order for a refugee to get RMA assistance, they first must apply for Medicaid. They must be denied Medicaid for one reason or another, and then only after they are denied Medicaid can they apply for the RMA coverage. Even with all of that, though, the RMA coverage is only good for the first 8 months after their arrival, not after they apply, not after they get service, but only 8 months after their arrival. So even if a refugee applies for Medicaid on day one, they have to wait for that process to go through, wait to get denied, and then have to apply for RMA. Every day they're waiting for their Medicaid denial and for the RMA to go through, they are losing time where they could be covered in those 8 months. As I mentioned earlier, a lot of refugees, a lot of people in general, don't often seek out healthcare until they need it. So if a refugee arrives, doesn't have any health issues, they might wait a month or two until they have a health issue to even apply for Medicaid, get denied, then have to apply for RMA. That all counts towards their 8 months. So if they arrive January 1st and they don't apply for RMA until August 1st, they only get it for a month. They don't get it for 8 months from that point. Once their 8 months is up, then they're expected to either qualify for Medicaid, get private insurance, get insurance through the marketplace, or through their jobs. So it's a good program, it's a good policy, but there are a lot of issues with it that could be tweaked to make it better for refugees who resettle in the United States. There is another quick update I want to mention on this too, though. In October of 23, so last October, the Office of Refugee Resettlement, ORR, issued a policy letter that allows for any states to apply for a waiver to allow full-time refugee students in higher education to apply for RMA. This again might not seem like much, but previously RMA was limited to individuals who were not full-time students in higher education. So this does expand the access to it, giving those students who are full-time in higher ed access to RMA, but only if the state applies for the waiver. Now, will Tennessee apply for this waiver? I have not seen that they have yet. Knowing how Tennessee does things, it's not likely, but there is a way to kind of maybe push local leaders to be aware of this waiver, to apply for it and expand RMA services to refugees who are full-time students in higher education. So while the Refugee Medical Assistance Program is there to help, again, a lot of barriers, and for the most part, most refugees end up having to rely on Medicaid, if not completely, then after their RMA ends. So just a quick look at how this affects Medicaid status for refugees. Of course, TennCare is Tennessee's Medicaid. And as I previously mentioned, Tennessee is one of only 10 states now that has not expanded Medicaid. This would also give more access to refugees to get qualified for Medicaid if Tennessee were to expand. So that's another fight that we need to keep pushing. So, but a brief overview again, TennCare is the Medicaid program. Cover Kids is Tennessee's children health insurance program. TJC did host a webinar about TennCare and Cover Kids eligibility and immigration status more broadly. That was a few weeks ago. You can, if you weren't able to attend that, you can visit our YouTube channel to see that webinar. The big thing that comes in with refugees here, TennCare and Cover Kids is available, as you can see on the screen, to U.S. citizens, U.S. nationals, and qualified non-citizens. Refugees fit that box as a qualified non-citizen, so they're eligible for it. The reason they're often denied it is due to income, due to other issues, but they are qualified non-citizens, so they are eligible, and they do not have to wait the 5 years. They don't follow under one of those groups that has the 5-year bar. So they are eligible right away. Still, there's a lot of research that shows they haven't been able to access it maybe as frequently as they should. Cover Kids does help again, especially when it comes to pregnant women, since it covers pregnant women regardless of immigration status until 60 days postpartum. And again, good program. It does help, but anybody who's had a child or been around children, you know, stuff doesn't stop 60 days after birth. They still have issues. They still need coverage. So it's more of a Band-Aid than anything, especially for these vulnerable populations. So if a refugee can't get on RMA or has used its RMA, can't get on Medicaid or TennCare, then they're often directed towards the marketplace. One of the reasons they're directed towards the marketplace, many of the refugees, when they resettle, they do not have jobs that offer insurance to them. So that creates another barrier. They often don't make a lot of money at the jobs they have, especially starting off. But the marketplace is a place where they can go. Of course, many of you are getting familiar with the marketplace, where consumers can get help understanding their options and getting health plans. Registration period does create some barriers. Again, refugees can arrive anytime, might not be able to wait till the registration period. They could arrive and get special enrollment as they are just arriving. But again, a lot of times that's not first thing on their mind. They could arrive, they might wait too long after they got here and not qualify under special enrollment and then have to wait until the registration period. So a lot of barriers with that. And some other barriers when it comes to refugees in the marketplace, it's a very confusing process, especially for refugees who don't speak the language, who don't know the policies, the cost. Oftentimes, many of the refugees do not make enough to afford marketplace plans. They may not qualify for some of the discounts or credits. They may not know about them. They may not know what insurance is, depending on where they came from. So this is a very dangerous place, if you will, for refugees to try to get healthcare insurance when they have literally no idea what they're doing and no idea what they need, and then can't even read the forms they have to fill out. So, and the same is true with Medicaid, with TennCare, even with the RMA. These are all very, very confusing processes that are not easy for the refugees to figure out. So just as a quick little aside and a little antidote, I myself, my daughter has some health issues and qualified for disability Medicaid. And when I had to fill out her paperwork to enroll in the disability Medicaid, I am a native English speaker, lived in this country my entire life, and I struggled to complete these forms and to get them all the information they needed. And I ended up having to fax in over 100 pages of documents to get her on this part of Medicaid. This is not something that you can just say in 25, 30 minutes to a refugee, this is how you do it. These are very hard policies. And that's one of the things that we need more help with, is helping these refugees understand these policies, understand how to apply for them. Excuse me. So shifting focus just a little bit to a more specific healthcare issue, looking at refugees and family planning. So one of the biggest issues that refugees have, not just in Tennessee, but all resettled refugees really across the United States, is that many refugees suffer from unintended pregnancies. And there's many reasons for this. There's a bunch of research on this as well. But these unintended pregnancies, one of the easiest ways to prevent them is to have access to appropriate family planning services. So family planning or birth spacing is the ability to have the amount of children you want when you want them, or to not have children at all. Some of these barriers are kind of even expanded with family planning, because many of these refugees come from cultures that do things differently. And once they arrive in the US, they often have a lack of access to their traditional means, ways they did things before. Many of their cultures want large families, but as we saw with the idea of acculturation, they're pushed into becoming more American, for lack of a better term, to fit in with this new society. And American society does not kind of promote the idea of 8, 10 children like many of their traditional cultures do. In addition, having kids in the United States is expensive. And a lot of times refugees do not have the money for this. So they're trying to fight this balance between living with their traditional culture, living in this new world, and balancing how much they are going to kind of become members of their new society. Some other major barriers, unfamiliar contraceptives. Many refugees come from areas where modern contraception is not widespread. So not knowing about implants, not knowing about long-acting reversible contraception, such as IUDs, not knowing about implants. So they just don't even know what's there. They also have a limited understanding of the US healthcare programs and healthcare services. US healthcare is confusing to Americans. Imagine again, different culture, different language. In many places where refugees come from, they also have access to abortion. Abortion laws have been loosened in many parts of the world. The United States is one of the few countries that has actually strengthened anti-abortion laws. So coming from a culture where they may have had access to an abortion, again, creates another challenge. And then, of course, again, the Dobbs decision, trigger laws in many states, including Tennessee, those affect abortion, of course, but they also affect other issues. With some of these trigger laws in place, there's a fear of refugees that they could get deported for even asking about abortion or even discussing it with a provider. Now, refugees are a special status. They're not supposed to be able to be kicked out of the country or deported, but there have been instances of policies that have kicked refugees out. Even though they are legally settled, they are given Social Security numbers, they are qualified residents and they're on their way to their green card, they have still been deported. So the fact that they are afraid to even talk about some issues, afraid to even maybe ask for contraception for fear that that could be a part of them being deported, them being seen as a public charge, which again doesn't or isn't supposed to affect refugees. These are all issues when it comes to family planning services. And of course, on top of that, you have all of the other issues we already mentioned when it comes to language, culture, cost, etc. So what are some ways we can help refugees when it comes to family planning services, other sexual reproductive health services? And a lot of these are going to work for other groups, other classifications, so for immigrants as well. But traditionally, the place to go for family planning services and other sexual reproductive health services was the local county health departments. In Tennessee, local and county health departments received Title X funding to provide family planning services. However, that was only until April of 2023 when the Department of Health and Human Services stopped Title X funding to Tennessee, taking about $7 to $8 million back. And the reason that Tennessee lost this Title X funding was because that Tennessee state officials would not allow abortion to be discussed as an option. And one of the rules for Title X funding requires that all options are at least presented or discussed upon request. In Tennessee, there was also an issue that really hits closer to what this is focusing on, where state officials were requiring Title X clinics, especially the health departments, to ask immigration status of patients and to report those who were undocumented. So both asking and reporting immigration status by these health departments goes against the Title X rules as well. And so Tennessee lost this Title X funding. At the time, it was the only state in the US not receiving Title X funding. Oklahoma joined us in that because they did basically the same thing. But although Tennessee lost its Title X funding, county health departments, as of January of this year, were still providing family planning services. The state was just not getting the federal funding for it. And the federal Title X funds that were supposed to go to Tennessee through the state have been still getting to Tennessee through Planned Parenthood and through another company called Converge. Converge is considered the official Title X provider for Tennessee. Unfortunately, Converge is based in Mississippi, and they are currently building a clinical network with Tennessee providers. So that Title X funding is going to make its way back into Tennessee. It's just going to take some time. But with that said, Planned Parenthood is another place where refugees, immigrants, those of varying statuses can access sexual reproductive health services. A Step Ahead, which has a head office in Chattanooga, and I think in Memphis as well. Other kind of smaller nonprofits that work on sexual reproductive health services often give those to anyone at reduced or no cost. These are places where refugee clients, where immigrant clients can at least inquire about some of these services that they need. Another thing that can help with this is as of July 13th, 2023, the FDA approved Opill as the first over-the-counter contraception option. In March 2024, Opill was available in stores. So if the sole kind of maybe desperate need at the time is just getting on some type of contraception, some type of family planning to prevent a pregnancy, there are options, or at least an option with Opill as well. So this helps avoid many of the barriers, the doctors, the costs that refugees might face when you can just go to the store and get it. There's still, of course, major barriers about taking it appropriately so it's effective, but it is another um, option that's out there. And then some other kind of more generic or general ideas about ways to help refugees and immigrant clients. The policy of hospital financial assistance. Federal regulations require some hospitals provide charity and other community benefits. So definitely look into those. Talk to financial assistance office at the hospital. They can possibly forgive all or part of your bill. Um, So in some areas, as in Nashville, hospitals must have Spanish language skills or use translation service. And just a note on that as well, all hospitals are supposed to be able to provide interpreters for individuals who show up at the hospital and who not speak English. But that is another challenge, finding those interpreters, finding the ones that speak the right dialect or even the right language. I had a refugee that I knew who went to the hospital for some reason, and the person they went by themselves. The person speaking to them was like, "Oh, I don't know what you're saying," and went and got an interpreter, and the interpreter spoke Arabic, and the refugee didn't speak Arabic. They just assumed based on the way they looked that it was Arabic they're speaking, and it's there's a lot of challenges when it comes to stuff like that. So there are options for assistance. There are avenues to look at. So just be aware of those. And then another program is the Community Health Access Navigation in Tennessee, known as CHANT. This is administered by Tennessee Health Departments and provides an integrated model of care coordination that provides enhanced patient-centered engagement, navigating the systems. Individuals who are eligible include pregnant and postpartum adolescent women and children birth to 21. Again, a great program, but for a lot of our populations being refugee or immigrant, many of them are over 21 and are not pregnant. So this really wouldn't qualify for that. Many of them who are pregnant may not speak English. The chant program does not have interpreters that speak Kinswasha or some of these other languages that refugees speak. So as much as you might try to coordinate their care, if you can't communicate with them, it creates problems. Most refugees, when they resettle, they have case managers or caseworkers from the resettlement agencies that can help them with a lot of this as well. But those services are only provided for a year after resettlement in most instances. So still some barriers. And then, of course, the other big barrier here is that the CHAMP program is administered by the health departments. And we've already mentioned that many immigrants and refugees are not necessarily comfortable going to health departments because of this policy where they were being asked their refugee status, being reported by the health departments. There's not a lot of trust between immigrants and refugees and the state of Tennessee and its entities based on previous and current policies. So while it may be a good policy or a good program, it's limited in who can do it and limited in who might want to do it because of who's running it. So those are kind of some of the barriers. And again, I focused a lot on refugees and I focused on sexual reproductive health and family planning, but a lot of these things are transferable to other immigrant populations, to even other health areas of health service. But there are some ways to help. There's a lot that can be done better. There's a lot that needs to be done better. And so we at Tennessee Justice Center, many of you in your work that you do with immigrants and refugees are doing what you can to help as well. And so hopefully some of these things maybe just highlighted something you weren't aware of, some other area that you might be able to take advantage of to get refugees and immigrants some of the access to healthcare that they need. So with that, I'm going to go ahead and open it up for some questions. I do see that there is one here now. So um, someone asked about options for people with disabilities who don't qualify for SSI. That is a great question. And I know that that comes up a lot. And I will unfortunately say that I am not the person to ask for that. The I would say that that's a reach out to Tennessee Justice Center, and we could probably put you in contact with the right person. I do not know off the top of my head. And I will preface this and apologize by saying that I defended my dissertation last month, and for the last 2 years, I've been so focused on just refugees and just sexual reproductive health that I am not up to date on all of the other policies that seem to be constantly changing. So I apologize for not having a better answer for that question, but I do think that there would be someone at TJC who could provide you with a better answer and with some options. But yeah, so if anybody has any other questions about refugees in the state, about refugee policies, about healthcare access or challenges, I will do my best to answer them. And we've got plenty of time. If nobody's got questions, I can start just diving into more pages of my dissertation and start reading them, because we know there's plenty of that out there as well. All right, I got a question here from, now it looks like, are Tennessee's refugee healthcare access services still suffering from Trump era refugee caps? And have you seen any lasting effects? Yes. So when the Trump era refugee caps, one of the biggest things that happened there was the way refugee resettlement is done is resettling agencies get paid based on the amount of, or get refunded from the government based on the amount of refugees they resettle. When he put on caps and even just shut down the refugee resettlement program for a while, less refugees got resettled, less money went in, and we saw numerous closures of resettlement organizations across the US. But in Tennessee, one of the bigger things we saw was less funding for the 4 resettlement agencies in the 4 big cities. And that meant a lot of times drawback on their staff, less social workers, less people to help get them to the services they need. let them have transportation to appointments, etc. So it's all kind of a spiral of when you start to lose funding, you start to lose accesses and resources, and that has not quite recovered yet. The numbers have been going back up. President Biden and his administration said that they were going to jump the numbers back up, but it's been a slow process. And unfortunately, there's not a lot of political capital when it comes to refugees because everybody ties it into what's happening on the southern border, which is a completely different situation. So, with some of the individuals that I know that work at refugee resettlement organizations, they have fewer employees, they have fewer caseworkers, they have more refugees to deal with and less time to spend with each one. And that's probably the biggest suffering for access, because those caseworkers are the ones who are able to give them direct answer as quickly as possible. Another question, what do you consider a better option after RMA when clients don't have stable income? And then recommending marketplace. I think, honestly, usually marketplace is the only option. I think that Medicaid is the best option if they can qualify for it after their RMA. But again, most of them, marketplace is really going to be the only option they have, because once their RMA goes up and they're not qualified for Medicaid, or then they're not going to often have jobs that provide it. They're not going to have stable incomes. I think one of the keys is we kind of have to be vigilant in getting people who can help them navigate the marketplace and help them get plans that are good for them, that work for them, that they might be able to afford, to make sure they qualify for the tax credits or the discounts. Honestly, I would say if they qualify for Medicaid after their RMA expires, that would probably be the best option. But marketplace would be the next best option then. Got some here in the chat as well. Is there any way to keep them on Medicaid while they wait to naturalize? This all just boils down to the general rules for getting on Medicaid, especially the income, because again, it's a double-edged sword. They're pushed to be self-sufficient as soon as possible. The sooner they become self-sufficient, they start making more money, start maybe getting better jobs, then they're not going to qualify for Medicaid. Maybe the bright side with that is refugees do have special status. They get a social security number upon arrival, and instead of waiting 5 years for naturalization, they can apply for their green card after 1 year. And so they have kind of an expedited process to naturalization. Now, again, it's upon them to actually follow through with that, to make sure they're doing all the stuff. But that seems, in my experience, that seems to help them get maybe off Medicaid and onto employer insurance because of better jobs quicker than many other immigrants who have a much longer process to get settled. I'm sorry, Kristen, I hope that answers your question, but I think, and I might have to refer back to the webinar we had last week or 2 weeks ago. I think that technically they're allowed to stay on Medicaid for 7 years total once they arrive as refugees. So in many cases, if not most cases, while they're on that Medicaid, as long as they're not disqualified for some other reason, they can make it to naturalization while being on Medicaid. The biggest issue is just often not qualifying for it in the first place. Amelia, any resources in Middle Tennessee for immigrants who do not have access to Medicaid because not here legally? I mean, my first answer, of course, TJC would be a bit of a resource to try to help out, find what's out there. More specifically, when it comes to especially what I focused on, places like Planned Parenthood, A Step Ahead, usually are very low cost, or even free. For more general health, I'm not familiar with the Middle Tennessee area. I'm more in the Knoxville area, but TJC would probably be able to provide you a good list of what resources are in specifically the Middle Tennessee area there for that. Lydia, the big need to help people who are considered as foreign traffic victims who are given eligibility with the same benefits and rights as refugees. Yes, so Lydia was asking about foreign trafficking victims who are given an eligibility letter that gives them the same rights and benefits as refugees, and many benefit agencies don't know about this. That's the example you gave there with asked to show proof. They need a social security card to get benefits. They have to apply for 10 care and get a refusal. That's one of the unnecessary steps that see with refugees. Even though refugees are given a social security number when they arrive, they still have to, apply for 10 care before they can get their RMA. And, that's a hugely unnecessary step, especially when the RMA is limited to 8 months. I don't know. There's got to be a way to avoid, like in that specific instance, with the need for the SSC to get the. I feel like that's where, and I know I'm kind of just beating around this question because there's not a good answer. First and foremost, Tennessee needs to expand Medicaid, which will help in a lot of ways. We need to keep pushing that. I think we need to make sure that, these benefit agencies, and not even the benefit agencies, but even those people like yourself who work with them, that they are fully aware of issues like this. So A, they can be prepared for them in the first place, and B, we can use that knowledge to start kind of saying, look, these are some changes we need to push for. That's, I'm not can't guarantee anything because I'm only an intern, but that's things that we like to do at TJC. Those are advocacy things that we can start pushing for, that we can try to bring up with lawmakers and to try to make a change so we don't have those unnecessary steps. So if the refugees have a U visa, or what is their status according to USCIS? I just was looking at something on this not too long ago. I do know that they're given an arrival record. I want to say it's maybe the I-94, which specifically labels them as refugee. When they apply for their green card, it has a refugee status as opposed to some of the others. There's so many I don't know the UC or USCIS status is off the top of my head. Um, the general understanding that I've been given is that they're basically given basically a refugee identification card, which works as their kind of legal identification. It has them labeled as refugee status, which gives them certain benefits that other immigrants and other IDs don't. And they are eligible to start applying for their green card within a year or after a year of being in the country rather than the longer wait for others. So, sorry, I did not answer that question very well either, but that's the best I know off the top of my head. And kind of going along with that, and this might sound harsh, but half the time I feel like, especially in Tennessee, nobody knows what's going on because you have policy changes all the time, you have different status. Everybody often groups refugees and immigrants and asylum speakers and all those groups together, even though they all have, as you mentioned, they all have different statuses, they all have different benefits or rights based on their status. And it just reminds me I want to say it was 2022 or 2023, the Tennessee legislature had this whole working group on the status of refugees in Tennessee. And not a single thing they did in all of their interviews and all of their messaging, all their meetings, none of it actually dealt with refugees. They were actually looking at undocumented children being brought into Tennessee and then either being placed here or being sent to other states. And if you read through the documentation of all of their interviews with the people, they brought in people from the refugee clinics and refugee resettlement agencies, and they asked them all these questions, and they weren't even about refugees. And so they named this whole working group and this whole report, the status of refugees, and it wasn't even about refugees because everybody just uses these names interchangeably. And that's one of the biggest issues is we need to make sure we're using the proper terms, the proper classifications, because if not, it can completely change what services, what benefits, what people are eligible for. So, and I think we've got time for about one more question if anybody else has anything. These have been some great questions. And again, I apologize that I am not directly into the policy enough or actually working with the refugees enough to know some of these answers. I would recommend, the specific questions about stuff like Yuli's question, definitely reach out to kind of wherever you are, but Bridge Refugee Services in Knoxville or Chattanooga, who do the resettlements for those cities, Catholic Charities in Nashville, World Relief in Memphis, specific details like that. Those refugee resettlement agencies will be able to give you the answers right off the top of their head. And then, TJC and our health equity side, some of those questions or some of those issues with where to go, especially Middle Tennessee, they should be able to give you some more assistance on those as well. So I appreciate all of you coming and attending. I appreciate the questions. Again, I hope that if nothing else, you were able to take a little bit of something here that may help you work with your clients, with your friends, with whoever you're working with or whatever you're doing, and give you just a better idea of some of the challenges that refugees face, especially after they resettle in a place like Tennessee, which is not always the most welcoming when it comes to policy or legislators. but still we rank 18th. So we get a lot of refugees, they need a lot of help. We have a lot of immigrants, they need a lot of help. So I commend all of you who are working with them to get them that help as well. And we will keep fighting the good fight. Again, my email address is up there. If you have any questions or something pops in your head later, feel free to reach out to me. I will respond as soon as possible, and I will help you find the answer if I don't know it. So thank you again. I hope you all have a great day and a great weekend.